Tama na po. Can you see screen? Can you see my slide?
Yes po, Doc.
This one I sent already, right? Kung utang ko na lang is Meno po. Okay. So, our first topic is abnormal uterine bleeding. So, for those who are presenting on December 10, listen carefully because this is, particular to my group. And well, for everyone, when you are given a case that has chief complaint of irregular menses, heavy menstrual bleeding, your differential diagnosis, special number one is still pregnancy, especially in the reproductive age. And then you start and then the other differential diagnosis, you start your phrase as abnormal uterine bleeding, secondary to. Anyway, so women with AUB suffer diminished quality of life, they lose work productivity, and when left untreated and prolonged, it utilizes expensive medical resources. So this is the normal limits. You have normal interval between menses is 28 plus minus 7 days. Your oligomenorrhea is more than that of the normal interval menses. So that is 28 plus 7, 35. So more than 35 days. Your polymenorrhea is less than 21 days. Mean duration of menstrual flow is 4 days and prolonged menstrual flow is more than 7 days. So an 8-day duration is already prolonged. Average menstrual blood loss is 35 ml and heavy menstrual bleeding is quantified as more than 80 ml. This is the FIGO classification of causes of the abnormal uterine bleeding. So it has a mnemonic which is PALM-CoN. PALM, this side as having structural causes, and this side, the CoN side, as something as having non-structural causes or the organic causes. So for the non-structural causes, you have your polyp, which is localized overgrowth of endometrium containing endometrial glands, stroma, and blood vessels. Majority of endometrial polyps are benign. It has an increased risk of malignancy if it has symptomatic vaginal bleeding in postmenopausal status. It has actually a low risk of it becoming benign as low as 0.3%. So how is it written? It can be abnormal uterine bleeding if it's spelled out, abnormal uterine bleeding secondary to endometrial polyp, or this one, AUB, E1, A0, L0, M0, T0, O0, E0, I0, and 0. Or the shortcut is this one, AUBP. Okay. Next is adenomyosis. Adenomyosis, there is presence of endometrial glands and stroma in the uterine myometrium. Presence of ectopic, it is also characterized as the presence of ectopic endometrial tissue, which leads to hypertrophy of the surrounding myometrium. Usually, it has in ultrasound, you have a thickened myometrium with coarse echo pattern with posterior acoustic shadowing. So these lines here are acoustic shadowing. A histologic diagnosis is usually a histologic diagnosis, just like the pelvic endometriosis. But findings of an enlarged asymmetric uterus on ultrasound and MRI are indicative. So this is how you write it. AUB-A is the shortcut. So next is the L, or the leiomyoma. It is also known as your fibroids. It is a benign tumor of the uterine myometrium with a complex and heterogeneous clinical presentation. Mechanisms by which fibroids cause abnormal uterine bleeding are varied and depends on size, location, and number. So if the leiomyoma is submucosal, by location, a uterine a myoma with abnormal uterine bleeding that is heavy is usually submucosal. However, even if it's an intramural myoma, but if it is large and encroaching already on the endometrium, it can also cause heavy menstrual bleeding. And it follows also that the more the myoma our uterus has, it has a more propensity to have abnormal uterine bleeding. So this is the leiomyoma subclassification system. Your O is a pedunculated intracavitary. It's 0 to 8. So it's 0, not O. So 0 is the pedunculated intracavitary submucous myoma. 1 is when you have a more than 50% submucosal myoma. More than 50% submucosal. Okay. So don't get confused. It's more than 50% submucosal, meaning it's less than 50% intramural. For 2, it's less than 50% in submucosal. For 3, here, it's intramural but is in close contact with the endometrium. 4 is purely an intramural myoma. And 5 it's an intramural myoma with less than 50% subserosal structure. Component, subserosal component. A 6 would be a subserosal myoma with less than 50% intramural component. And 7 is a pedunculated subserous myoma. So you have the 8 or others in which it is either parasitic, usually in the broad ligament or cervical. Hybrid leiomyomas are 2 numbers that are listed separated by a hyphen. For example, if you have 3 myomas, one is in contact with the endometrium and the other is has a subserosal component. If it's a hybrid leiomyoma, meaning it's a myoma that encompasses 3 classifications or 3 subclassifications. So for this one, a number of 2 to 5 would mean that this myoma is actually has a less than 50% submucosal component, but extends up to the serosal layer. Okay, so it's just like this 2, except that it extends up to the serosal layer, up to here. So it's 2 to 5. Okay, and it is written, as a shortcut as AUB-L. Lastly, for the structural cause is malignancy. It can either be vaginal, cervical, endometrial, uterine, or adnexal. Other pre-malignant conditions are also included here. So, pre-malignant conditions include your endometrial hyperplasia, CIN, your cervical intraepithelial neoplasia, and EIN, which is your endometrial intraepithelial neoplasia. Cervical cancer is one of the most common malignancy that presents as postcoital bleeding, and endometrial cancer most commonly presents as abnormal uterine bleeding. Its abnormal uterine bleeding is similar to that with an ovulatory pattern, irregular, that is, and prolonged. Okay. We go now to the non-structural or organic. For C, or the coagulopathy, encompasses the spectrum of systemic orders of hemostasis that may cause abnormal uterine bleeding. For adolescents, post-prolonged menses, it is a routine screening for coagulation defects, especially when the prolonged menses begin at menarche. In adults, screening is of little value unless otherwise indicated, which includes bleeding gums, epistaxis, or ecchymosis. This is the irreversibility. Most common coagulopathy is the von Willebrand disease, followed by your prothrombin deficiency. Other coagulopathy are your hemophilia A and B that are more famous, and others are inherited coagulopathies of the clotting factors. Chronic anticoagulation as a result of heparin, low molecular weight heparin, direct thrombin inhibitors, and direct factor 10A inhibitors also falls under this category. And it is written as AUBC. Although your heparin and thrombin inhibitors are technically iatrogenic because they are given as medications, they are considered under C because they interfere with the blood clotting pathway. That's why it's under coagulopathy. Your O is your ovulatory dysfunction. It is also formerly known as the anovulatory type of dysfunctional uterine bleeding. It is abnormal uterine bleeding secondary to an ovulation. It happens during extremes of reproductive life, either during menarche or at premenopausal period. There is continuous estradiol production without corpus luteum formation and progesterone production. In short, there is unopposed estrogen. The steady state of estrogen stimulation leads to a continuously proliferating endometrium, which may outgrow its blood supply or lose nutrients with varying degrees of necrosis. In contrast to normal menstruation, uniform sloughing of the ovisalis layer does not occur, which produces your excessive uterine bleeding. Examples here would be your polycystic ovary syndrome, your hyperprolactinemia, hyperandrogenism. In a way, hyperthyroidism also. And it is written as AUB-O, or this is for the long cut. Your AUBE, or endometrial pathology, is formerly known as the ovulatory type of DUB. There is heavy menstrual bleeding in the absence of other abnormalities. Primary line of defense to excessive bleeding during normal menses is the formation of the platelet flag. This is followed by your uterine contractility, which is largely mediated by the prostaglandin F2 alpha. So the theory here is that the endometrium has a deficiency in the prostaglandin F2 alpha, or something in the component, something along the inflammatory process initiated by the prostaglandin F2 alpha, which whereby causes the uterine contractility. This, however, is a diagnosis of exclusion, meaning everything is normal. Coagulopathy is already ruled out, no anovulation, and the pattern of bleeding is regular, monthly, not prolonged duration, meaning up to less than 7 days, but with excessive bleeding. The bleeding is more than 80 ml per period or per cycle. And this is how you write it, AUBE. Most residents and some of the interns miscorrectly classify endometrial hyperplasia as AUBE. Please do not take that mistake as well. Do not adopt that mistake. Your AUBE is an endometrial pathology, whereas endometrial hyperplasia is under malignancy. It's a pre-malignant condition of the endometrium. Therefore, your endometrial hyperplasia falls under the category of malignancy. It's not the same as the AUBE, which is endometrial pathology. So in endometrial pathology, there is an intrinsic abnormality in the endometrium, which is theorized as the one that is mediated by the prostaglandin F2 alpha. Your eye is iatrogenic and it's secondary to the medications given. Most common are your oral contraceptives, progestogens, and progesterone implants. Your GnRH agonist can also be can also cause abnormal uterine bleeding, but not as common as your progesterone implants. Drugs can cause hyperprolactinemia, can also be iatrogenic. Examples would be your OCTs. Your OCTs can also increase hyperprolactinemia. And some antipsychotic drugs. Okay, so AUB secondary to heparin does not fall under this category. And this is how you write it, AUB-I. So for not otherwise specified, abnormal bleeding is not classified in the previous categories. Examples of these conditions may include foreign bodies or trauma. In the FIGO classification, arteriovenous malformations and myometrial hyperplasia also fall under this category. And this is how you write it, AUB-N. So what are the workup? So this one is shamelessly copied from your Gyne. There should be focused assessment of the abnormal uterine bleeding. So in your history, you will ask for the bleeding pattern. In the history, you also ask for symptoms of anemia, usually in the form of headaches, palpitations, shortness of breath, dizziness, fatigue, and pica. Pica for oats is an indication for iron deficiency. Okay. I just discovered that when I was in fellowship because I have heavy menstrual bleeding and I suddenly had a pica for oats, as in the raw oats. Apparently, I have iron deficiency at that time already, like a hemoglobin of 70. Also ask for sexual and reproductive history, specifically the use of contraception. Sexually transmitted infections, cervical screening, possibility of pregnancy, desire for future pregnancy, and if there's no infertility. Also ask for associated symptoms, fevers, chills, increasing abdominal girth, pelvic pressure or pain, bowel or bladder dysfunction, vaginal discharge or odor. Dysmenorrhea will also fall under these associated symptoms. Symptoms associated with the systemic cause for AUB. So overweight and obesity can lead to either a PCOS or hypothyroidism, hyperprolactinemia, hypothalamic or adrenal disorders. For chronic medical illnesses, your coagulopathy falls under this, and you usually ask for esibrosubility and gum bleeding. SLE or other connective tissue diseases can also cause AUB, so you have to rule out for this one as well. How do you usually rule this out? Most patients will not tell you that we have this certain type of disease. But when you ask for medications or maintenance medications, that's the time when you will find out that they are taking certain drugs for specific disease, like your SSRIs, because apparently they have been diagnosed with depression, anticoagulants, because they have previous heart attack before, something like that. And then also ask for hormonal contraceptive use. As actually one of the most common cause of abnormal uterine bleeding is actually the use of OCPs, well, secondary to pregnancy. Coagulation or thromboembolic disorder should also be ruled out in presence of hormone-sensitive cancers. So in this case, ruling out a hormone-sensitive cancers will affect your management. Meaning you cannot give hormonal medications for patients that are hormone sensitive, that have cancers that are hormone sensitive. For the physical examination, blood pressure, well, vital signs are important. And as with those who have already under me in the ward work, I always place the height and weight so that you can compute the BMI. The neck exam, take note of any enlargement in the thyroid. As for the abdomen, take note of any tenderness, distension, presence of striae, any palpable masses, and hepatomegaly. Hepatomegaly more of points to a possible thrombocoagulopathy, problems in the platelet. So in the skin, take note of any pallor, any bruising, any petechia, or signs of hirsutism. And then for the pelvic examination, examine the vulva, the vagina, the uterus, the anus, and the urethra, aside from the uterus. If bleeding from the rectum is suspected, do a rectal examination. The pap smear is done in the absence of abnormal uterine bleeding at the time of consultation. If you are highly considering for a sexually transmitted infection, then do guided cervical cultures. So what are the laboratory workups? First of all, rule out any presence of pregnancy. So beta HCG, whether serum or urine, should be done, regardless of age. Well, unless you trust the patient to be not lying, then okay. If they said that they are not pregnant, they have no contact for a few months or so, then you may do away with the beta HCG. But with unreliable patients, always perform preg test. Believe me, you have to do pregnancy test. I've had patients, it doesn't matter if if they finished elementary, high school, or college. They come to me saying that they are virgins. And yet, when I do the pregnancy test, it's positive. Always do complete blood count with platelet count as well. Other laboratory testing, the following can be done, but if it is clinically indicated. TSH for any suspicion of a thyroid mass or a thyroid problem. Free testosterone for patients with polycystic ovary syndrome and hyperandrogenism. Prolactin for those suspected of a hyperprolactinemia. Your PTP, PT, fibrinogen or thrombin time for coagulopathy. Of course, TVS is always necessary. Your SI is saline infusion on hysterography. This procedure is important when you are to diagnose an endometrial mass. So as the name implies, you place saline inside the uterus during sonographic imaging. So other laboratory workup would be your endometrial sampling, if clinically indicated, and office hysteroscopy, if clinically indicated. So for any disorders, of hemostasis in patients with excessive menstrual bleeding, there should be a structural medical history. This one, you do this if you have a high index of suspicion, especially if the patient is in its early menarche phase, meaning 1 to 2 years from the menarche, or in the 40s. Women in 40s are usually prone to ITPs, idiopathic thrombopenic purpura. So, you do a positive screening result comprises the following circumstances. Every menstrual bleeding since menarche, one of the following conditions. There is postpartum hemorrhage, surgery-related bleeding, and bleeding associated with dental work. We are more familiar or suspicious if the bleeding happens during dental work. If the presence of these two or more of the following conditions are also present, then it's considered a positive screening result, which includes bruising 1 to 2 times per month, epistaxis 1 to 2 times per month as well, frequent gum bleeding, and family history of bleeding symptoms. So these patients should be considered for further evaluation, including consultation with hematologists and testing for von Willebrand factor and distocetin cofactor. Treatment. So treatment for structural causes of AUB. These are for chronic AUB. Okay? Mainly, for structural causes, they are mainly surgical. For endometrial polyp and submucous myoma, small submucous myoma, hysteroscopic removal is the gold standard. That is why I asked this for the group presenting with AUB, what is hysteroscopy? Not only is hysteroscopy diagnostic for submucous myoma, it's also therapeutic, especially for small submucous myoma. The same applies for endometrial polyp. Hysteroscopy is both diagnostic and therapeutic. For large leiomyomas, regardless of the size, myomectomy or hysterectomy is indicated depending in the fertility goal of the patient. If the patient already has a completed family size, then she may opt to go for hysterectomy. But if she's still desirous of pregnancy, then myomectomy is the better option. For malignancies, surgical treatment is also the definitive management unless desirable of pregnancy. And she fits the criteria of being able to undergo fertility conserving procedures. Of course, in cases of malignancy, all should be co-managed with a gyne oncologist. In general, for chronic AUB, treatment is mainly medical. In general, but for the structural causes, especially endometrial polyp, mucosa, actually for structural causes, they are mainly surgical. But for chronic AUB that are organic, treatment is mainly medical. As for the case of ovulatory dysfunction, in adolescents, always rule out coagulation disorder. But main direction of therapy is to temporize because with time, there is maturity of the HPO axis and the problem will be corrected. Cyclic progestogens are preferred for adolescents because giving estrogen, especially those more than 30 micrograms, will cause the epiphysis to close. So the maximum so that the height of the adolescent may not be achieved or maximized. Okay. The potential maximum height of the woman when given estrogen is not achieved because of the early closure of the epiphysis if you give a combined OCP. So for adolescents, the ideal is to give a cyclic progestogen or a very low dose OCP. For those perimenopausal patients with ovulatory dysfunction. Your low-dose OC oral contraceptives or cyclic progestogens are applicable. There is much variability and unpredictability of the cycles because the HPO axis is in flux, moving towards ovarian failure. Bleeding, therefore, is more difficult to control compared to adolescents. In patients with polycystic ovary syndrome or PCOS, COCs, combined oral contraceptives or cyclic progestogens are also given. Remember in the PCOS, if there is an opposed estrogen. So, a better treatment would be to go for a cyclic progestogen as the patients already have high level of estrogen. If the patient is desirable of pregnancy, ovulation induction is advised, so refer the patient to your friendly infertility specialist or fertility specialist. Okay. That's an ovulatory already. For the AUBE, which is endometrial, the aim of therapy is to reduce the amount of excessive bleeding and prolonged regimen of progestogen, 3 weeks each month. This is for the E. So reduce the amount of excessive bleeding. Your oral contraceptives reduce blood loss by at least 35% in women with AUB. Your LNG-IUS or levonorgestrel containing intrauterine system is an effective duration of action because it has a longer duration of action, which is more than 5 years. And it can decrease blood loss by as much as 80%. So this is the Mirena. This is also known as Mirena or your LNG-IUS. It reduces mean blood loss. MBL is mean blood loss by 74 to 97% and is effective in increasing hemoglobin levels. It can also decrease dysmenorrhea. So this is also good for adenomyosis. And it can also reduce blood loss caused by fibrosis and adenomyosis. Patients with AUB due to coagulopathy can also benefit from this because they can be managed successfully by your Mirena or LNG-IUS. Your NSAIDs actually are also a good treatment for AUB. Remember, there's something wrong with the prostaglandin pathway. So your NSAIDs are cyclooxygenase inhibitors and block the formation of both thromboxane and prostacyclin pathway. You actually want the NSAID per se, not the celecoxib, the one that have COX-2 inhibitors. That one. The NSAIDs that you want are those that have these cyclooxygenase inhibitors. COX-2. Or something like that. Because they act on what is lacking in the prostaglandin S2. Other medications, for the NSAIDs, the ideal dosages are, for mefenamic acid, it should be 500 milligrams 3 times daily. For ibuprofen, it's 400. Your meclofenic sodium is 100 milligrams. Naproxen is 270 every 6 hours. Antifibrinolytic agents can also be used, and the most famous here would be your tranexamic acid. Honestly, I have never seen your EACA or ECA or aminocaproic acid. Also, your para-aminomethylbenzoic acid, I also haven't seen this. I am more familiar with your tranexamic acid. GnRH agonists may be used to inhibit ovarian steroid production as well as estrogen production. Unfortunately, after therapy was discontinued, blood loss returned to pre-treatment levels. This is not a good long-term treatment because it causes osteopenia in the long term. Also, if cannot be sustained. This cannot be sustained because it's expensive. Okay. So management of acute bleeding. In these cases, always rule out presence of hormone-sensitive cancers, and history of thromboembolism as you are giving high-dose estrogen. High-dose estrogen can cause thromboembolism and may be devastating for patients with hormone-sensitive cancers. So we give oral conjugated equine estrogen or CEE 10 milligrams per day. This is in IV form in 4 divided doses. So you give 2.5 milligrams IV every, so this one is every 3 hours. I think I need it. It's 2.5 milligrams in 4 divided doses. Every 6 hours. Sorry, that's every 6 hours. Whether you give it via oral or intravenous, it doesn't matter. And then you evaluate after 24 hours. If there's decreased bleeding, you now start with your progesterone or progestogen. You have to warn your patient that giving high-dose estrogen is very, can cause nausea and vomiting. So in this case, an intravenous form is more ideal because if given orally, then they have the tendency to just vomit the medicine. Okay, so that's for acute bleeding. Management, surgical therapy for acute bleeding, we may do dilatation and curettage. It is therapeutic and at the same time diagnostic. It is a preferred approach to assist in patients older than 35 years old. It is rarely curative. It is a temporizing procedure that causes immediate cessation of severe bleeding. But without treating the cause, after one menstrual cycle, the patient may have another cycle of heavy menstrual bleeding. One is dilatation and curettage. The next is endometrial ablation. The difference here is that you do not have a biopsy or a specimen for biopsy. Women who have large uteri caused by fibroids or abnormal pathology will not benefit from this procedure. A definitive management is hysterectomy or the removal of the uterus. It is reserved for women with other indications such as large leiomyoma or a uterine prolapse. Of course, this means that the patient is already not desirous of pregnancy. If medical therapy has failed, then we can now do hysterectomy. This one is made on an individual basis. Okay, anymore. This one is for our AUB. Menopause. We will now go to menopause. Okay. How to? Can you see the slides of the menopause?
Hindi pa po daw. Nasa thank you pa ng AUB.
Okay, sige. Sandali. Stop. Distinction. Ito.
Yes po daw.
Okay. This one, I just got it from the Google Drive as I seem to lost my copy. Okay, so this one is taken from Dr. Morante. Menopause in the care of the mature woman. Okay. So what is menopause? It's the permanent cessation of menstruation caused by failure of ovarian follicular development and estradiol production in the presence of elevated gonadotropin levels. So in effect, it's a hypergonadotrophic hypergonadotropin level. It means that you have an elevated FSH and LH but low estradiol production. So It has two types. You have the natural, in which there is 12 months of consecutive amenorrhea after depletion of ovarian reserves, with no known pathologic cause. So you have a um, qualifying amount of time, qualifying period of time, and that is 12 months of consecutive amenorrhea. In induced, it is either after surgical removal or iatric ablation of the ovaries. So this one is your hysterectomy or total hysterectomy or um, chemotherapeutic chemotherapy induced um, ablation of the ovaries. So you have the following terms. Climacteric is the physiologic period in a woman's life during which there is regression of ovarian function. Your perimenopause is the period prior to menopause where there are endocrine, biologic, and clinical manifestation of approaching menopause. So this is the period wherein the patient is starting to have irregular menses but still has her period. The postmenopausal period is the one that is referring to any woman who's achieved the definition of menopause, which is 12 months amenorrhea. Okay. So this is the stages of reproductive aging. So during the reproductive years, okay, we have the stages. 0 is the final menstruation period. Your -2 and -1 is the menopausal transition, which is considered the perimenopause. And after the final menstruation period, you have the postmenopause, or actually just menopause. So in the reproductive years, you have normal FSH. But in the late reproductive years, the FSH starts to increase around 20, 10 to 20 international units. In the menopausal transition, it becomes more consistent, maybe more having an average of 20 international units FSH. In the postmenopause, you can have an FSH as high as 40 international units. Okay, that's the only important there, the level of FSH. Age of menopause is genetically programmed event not related to the menarche, to the number of ovulations, to the race. So siya in a way, actually, it can be determined by race because of the genetics it plays. So the time that your mother had her menopause is the likely time that you will have, or sorry, for female students here, the time that you will have the age that you will have your menopause is the age when your mother likely had her menopause. So while you can ask them, while you can still ask them now or later after your lecture. But for a Filipino or a Filipina, the average is 47 to 48 years old. In Malay, it's 45. And for Thailand, or for Thai people, it's 49 to 50 years old. Menopause prior to age 40 is considered premature, and that is what we call the POI, or premature ovarian insufficiency. Premature ovarian insufficiency. Okay. So, what is the endocrinology behind? At the 28-week age of gestation, there is 6 to 7 million oogonia. These are for the female patients. At birth, only 100,000 oocytes are remaining until menopause. Actually, in a woman's reproductive years, only 400 are ovulated. Okay. So upon depletion of ovarian follicles, there is an increased secretion of FSH in response to elevate in response to decreasing estrogen. Because of this, the follicles mature irregularly, causing your irregular menses, causing the abnormal uterine bleeding. But despite depletion of ovarian follicles, despite decrease of estrogens, your theta and adrenals continue to produce androgens. There is aromatization of peripheral fats to estrone, but these are not as potent as your estradiol. However, there is no secretion also of progesterone since there is no ovulation. In theory, this results to unopposed estrogen production, which explains the development of endometrial hyperplasia or carcinoma if left untreated. So your failure of ovulation, because of these mechanisms, there is failure of ovulation, resulting to no progesterone secretion. There's decreased estradiol. The endometrium now fails to proliferate. You have a thin endometrium. And a thin endometrium will cause absence of menses or amenorrhea. Okay. These are the hormonal changes during the premenopausal and postmenopausal period. So the lighter blue is the premenopausal and this is the postmenopausal period. This one is for the E1 is the estradiol. I forget what is E2. I think it's the estrone. Your E is androgen. E is for testosterone, DHEA, and cortisol. So this is your FSH, LH, prolactin, TSH, and growth hormone. So relatively, your growth hormone and TSH have almost the same. So also for prolactin. But look here. Your FSH increases vastly like your LH in the postmenopausal transition. And then for your estrogen, it's the opposite. During the postmenopausal period, it decreases largely. I get it now. Sorry, your E2 is the estradiol. Your E1 is the, I'm not sure. I think the E3 is the estrone. Anyway, what I'm sure here is that the E2 is estradiol. The more potent estrogen form. The more potent form of estrogen. That's it. It's a better term. Okay. So what are the effects of menopause on various organ systems? And this is why we are discussing menopause. Okay. For the vasomotor changes, the most prominent would be hot flashes. It is the hallmark feature of declining estrogen status in the brain. It has an abrupt, unpredictable systemic physiologic phenomenon that takes place over a period of 30 seconds to 5 minutes. It is preceded by an increase in digital perfusion, which is followed by increases in peripheral skin temperature, somewhat similar to blush but more troublesome. The changes in the estrogen levels leads to alterations in the hypothalamic thermoregulation that are probably mediated through the central nervous system. Lower estrogen lowers temperature set point. So if the temperature set is lower, then you need it should at a higher temperature, leading to the body reacting at a lower temperature. So it becomes, so a lower temperature is already hot for them. Because of that abnormal thermoregulation, a lower temperature will result in the vasodilation in the skin and sweating. It is very uncomfortable and irritating at times. Actually, all the time, it is uncomfortable and irritating. You ask any patient that is having problems with hot flashes, they will tell you at all times. Okay. Psychogenic manifestations. You notice this also in your parents. Their sleep cycle is becoming shorter and shorter. They go to bed late, but they wake up early. They also may complain of tension headaches, easy irritability, depression, anxiety, poor self-image, and decreased libido. And one can go from irritable to depressed to anxious in 1 hour, actually in seconds for some. Okay. Second, second to hot flashes. The second most common complaint is the urogenital symptoms. One is urinary incontinence due to the changes in the vaginal and urethral mucosa. Second is recurrent urinary tract infection due to the changes in the flora. And in some, especially those who are multigravids and multiparous, pelvic organ prolapse is a problem because of the decreased elasticity of the collagen fibers of the pelvic ligament. Okay. Vulvovaginal atrophy is also a problem because of decreased lubrication, again because of the decreased estrogen, and then it now leads to vaginal dryness. Vaginal dryness leads to dyspareunia. Vaginal dryness is secondary to absent vaginal secretion, which causes the postcoital bleeding. Ayan. This one is the most significant urogenital complaint since it affects interpersonal relationship with a partner. So because of the vaginal atrophy, it leads to sexual dysfunction and it leads to impaired sexual desire and responsiveness. Yeah. Other systemic symptoms also can cause sexual dysfunction. Of course, if you have mood instability, it can lead to psychological stress. Then the patient will have no mood for sexual intercourse. Diba? Although the physiologic changes of menopause may in part contributory, majority of sexual dysfunction are due to psychological and psychosocial factors, not menopause itself. So it's actually a multidisciplinary problem. Another problem for menopause is osteoporosis. After menopause, in white and Asian women, bone density decreases at a rate of 1 to 2% for a year. Non-modifiable factors, white or Asian race, family history of osteoporosis, dementia, and poor general health. So this one, if you have this, it means you have a higher risk for osteoporosis. Modifiable risk factors, of course, low dietary calcium, low vitamin D intake, high caffeine intake, as this causes an increased loss in the calcium, high alcohol intake, cigarette smoking, chronic corticosteroid use, low body weight, early menopause, premenopausal amenorrhea of more than 1 year because of the absence of estrogen, and a sedentary lifestyle. So what are the methods to diagnose osteoporosis? X-ray. At least 25% of the bone needs to be lost before osteoporosis is diagnosed. So when you use X-ray, it's already quite too late. What is a better method is to do the DEXA scan or the dual energy X-ray absorptiometry, which measures the bone mineral density as follows. So it is expressed as T-scores and Z-scores. You use Z-scores for patients having early menopause. So these patients are that have amenorrhea for less than 40 years old. Yeah, so that's for the Z-score. For the T-score, we use the T-score for menopausal women. The Z-score is for the reproductive age women at high risk for osteoporosis. How do you interpret? A T-score of between -1 to 2.5 is osteopenia. and an osteoporosis is a T-score having less than 2.5. It was also postulated that sex steroids block the action of parathyroid hormone, which causes the absorption of the calcium, thereby reducing the amount of calcium absorbed from the bone. Human osteoblast cells have estrogen receptors, and it is likely that estrogen decreases bone loss by acting directly on these receptors. Remember, it's also the one that is responsible for closing the epiphysis, the estrogen. So it's also responsible for the absorption because of the receptors. Also, estrogen increases calcitonin levels and prevents bone resorption. So without estrogen, decreased calcitonin levels means decreased a higher risk for bone resorption. Although the rate of bone formation is unchanged after menopause, the rate of bone um, what's this degradation, however, is increased because of the increased calcium loss and reformation. Your postmenopausal estrogen deficiency results in the increased rate of bone resorption. Sorry, that's resorption. There is more preference in the trabecular bone, which are the spine, than in the cortical bone. Cortical bone is your scalp. Sorry, head bone. Lifetime fracture risk in patients with osteoporosis is approximately 40%. And the one that is usually involved is the femoral neck. Okay. Next problem would be cardiovascular changes. Your atherosclerosis is the major mechanism major mechanism is by direct action on the arterial wall and not on the blood. So decreased estradiol causes decreased prostacyclin, increased response to acetylcholine, and favors vasoconstriction. So actually, estrogen is protective to the blood vessels. Your estrogen also increases the HDL LDL ratio. So without it, it has a decreased HDL LDL ratio favoring formation of atherosclerosis. So whether hormonal therapy should be considered is an individual decision. It must take into account symptoms, risk factors, and individual preferences and needs. Predominant indication is to relieve symptoms, especially in the presence of hot flashes. Because hot flashes, aside from the blush, aside from the sudden heat, can also trigger irritability. Rationally in using HRT in menopause is to improve quality of life. HRT is hormonal replacement therapy. There is also flexibility in prescribing, and each HRT is unique in certain stages in the menopausal stage. So US FDA approved indications for HRT. Use it for treatment of moderate to severe vasomotor symptoms associated with menopause. Treatment of moderate to severe symptoms of vulvar and vaginal atrophy, and prevention of osteoporosis. So mainly, it's vasomotor, urogenital, vulvar and vaginal atrophy. This is where the urogenital symptoms come in. So you treat moderate to severe vasomotor symptoms, you treat moderate to severe urogenital symptoms, secondary to vulvar and vaginal atrophy, and to prevent osteoporosis. So what are the treatment regimens? Estrogen therapy should be given in the lowest possible dose that relieves the vasomotor symptoms. The optimal long-term dose of estrogen that should be given should be 0.625 of conjugated equine estrogen or 0.5 of the micronized estradiol. Your micronized, wait lang, let's see. 0.5. So this one, your estradiol patch is the 0.5. Your conjugated equine estrogen is the Premarin. The one that is available is the Premarin and is available in 0.3 to 0.625 preparations. And what does it say? You give it in the lowest possible dose. Your Progenova and Estrofem, I think Estrofem is not already available. Progenova is technically available but is currently out of stock in the country. You give it 1 to 2 milligram per day, but you start with 1 milligram per day. But in patients with local symptoms like the your genital atrophy, you can use Premarin cream, 0.5 grams 3 times weekly per vagina. So you have you have an applicator. The estradiol ring is 2 milligram ring every 3 months. So it's placed in the vagina through the cervix. Or the estradiol tablets. It's a 25 microgram tablet that is inserted per vagina twice a week. So if the patient only has a urogenital symptom, then you may opt to go for local treatment regimen. Women who have undergone hysterectomy are no longer at risk for endometrial cancer. Administration of estrogen without progestin is recommended for women who have no longer uterus, except for patients who underwent adenomyosis and endometriosis. If the patient underwent hysterectomy secondary to endometriosis and adenomyosis, then a progestin is recommended because anopause estrogen will lead to development of malignancy in patients with adenomyosis and endometriosis. So this one has an except ha. Oh, listen, I will ask that in the exam. For postmenopausal women with uterus, progestins are administered cyclically or continuously to reduce the risk of adenocarcinoma of the endometrium. Here. So, you give cyclic progestins for patients with adenomyosis and endometriosis because of a possible adenocarcinoma development. Okay. So treatment regimens, you have your cyclic regimen, which is using estrogen every day, and you are giving progestin for the first 10 to 14 days of the month. Your continuous combined regimen is both estrogen and progestin are administered every day of the month. So this one will result to negative menstruation. This one is technically positive menstruation, but because the patient is already menopausal, then there is no menstruation that occurs. Example of a continuous combined regimen would be Angelique. Progesterone for cyclic combined regimen, you have the 5 milligram medroxyprogesterone acetate or the MTE, 0.7 norethindrone, 1 milligram norethindrone acetate, and your 200 microgram micronized progesterone. Your Heragest or the other one, I forgot the name of the other one. Anyway. But we have a combined regimen, continuous combined regimen for the progesterone. You have a 1.5 milligram to 2.5 medroxyprogesterone acetate. This is continuous. The patient here will not menstruate. Another preparation would be 0.35 milligram. And then you have your norethindrone acetate, which is in by 0.5 or 1 milligram, and your 100 milligram micronized progesterone. What are the conditions that warrant the use of estrogen-progestin regimen? See here. Past history of endometriosis, supracervical hysterectomy, or what we are more familiar is subtotal hysterectomy. Past history of adenocarcinoma of the endometrium, and endometrial tumor of the ovary. Adenomyosis should also be here. What are the adverse effects of estrogen replacement therapy? The metabolic effects are increase in serum globulins. You have the angiotensin in hypercoagulable state, but the risks are very low. So you have to weigh the risk versus the benefit. Neoplastic effects. Of course, there's increased risk of breast cancer. You have also increased risk of endometrial cancer, especially with irregular intake of progesterone. If the patient has history of colon and rectal cancer, there's reduction in the risk of colon and rectal cancer. As for ovarian cancer, it is undetermined. Sorry, contraindications and cautions. It's not to be used in women with either diagnosed vaginal bleeding, of course, pregnancy. Well, we are talking about menopause anyway. Personal history of breast and endometrial cancer. Caution in patients with thromboembolic diseases and active liver estrogen. Also in patients who are smokers. Is there a need to do endometrial biopsy? These are for patients with natural menopause, meaning they still have they have an intact uterus. So indications for pre-treatment is if you have a previous unopposed estrogen therapy, patients have a characteristic high risk profile, and an endometrial thickness of more than 4 mm. This one especially in the presence of vaginal bleeding. Indications for endometrial biopsy during treatment is if there's anxiety and if there is endometrial thickness more than 4 millimeters. Women who choose to take estrogen progestin therapy should have a yearly breast exam by the doctor. They should also perform monthly breast exam and receive periodic mammography based on their age and risk factors. Actually, by the age of 40, sorry, 50. By the age of 50, a woman should have an annual mammography. What about androgens? The usual form of androgens is 5 mg methyl testosterone. By giving androgens, there is reduced peripheral conversion of androstenedione. But you give androgens if there is particularly problems in if there is sexual dysfunction, as it was believed that giving androgens will improve psychological well-being, especially in sexual relationships. But if you are giving this unchecked, it can cause virilization and may cause negative impact on cholesterol, lipoprotein profile. So again, you have to weigh the risk and the benefit. What are your possible alternatives? You're almost done. You have your phytoestrogens, your isoflavones in the form of soybeans, lentils, and chickpeas. Your lignans, which are in the form of flaxseed, cereals, vegetables, and fruit. I don't know how to pronounce that, but they are in the form of sunflower seeds and bean sprouts. What are the clinical effects of the phytoestrogens? Actually, it has insignificant effect. This is by studies. It has significant effect on the flashes, weak impact on coronary heart disease, no effect on the bone. So in this case, you have to give still calcium supplementation. It may be protective for the breast, but there is no effect on the endometrium and vagina. As for the cognition, it is unknown. What about raloxifene? Example would be your Evista, which is 60 milligram per tab. It is an option for prevention of osteoporosis. However, caution is practiced here because it can cause increased venous thromboembolism. So your raloxifene is a selective estrogen receptor modulator. This one is good for patients that have osteoporosis. What about tibolone? Actually, your tibolone is another estrogen modulator that can address hot flashes, vaginal dryness. It can improve sexual response and can prevent weight loss. This is our favorite for patients that are in their early stages of menopause. Why? Because it has no increased risk of venous thromboembolism, does not increase breast density, does not increase frequency of mastalgia, and it is usually has a safer profile or safest safety profile, if there's such a term, especially if the patient have comorbidities. So we have this international medical consensus. All women should be informed about the possible effects of estrogen withdrawal. And also, all women should be informed about beneficial effects of HRT. However, when you also say the beneficial effects, you should also discuss with them the contraindications, unwanted effects, and supposed risks of HRT. This is the last slide. Thank you. We've have over time. Any questions? I'm supposed to discuss the precocious puberty with you, but I'll just give you the slide. Anyway, I'll just take around 5 questions from the slides only. Hannah, when is your exam for this lectures, for the lectures?
For Gyne po, December 18 po, LE4.
So, advanced ba tayo? Yes, no?
Yes po.
Okay. May utang akong slides ng precautious. Hindi ko napipilitin kasi nung o'clock na. But I'll only take a few questions from the slides itself na. But, well, as much as possible, try to read from the compre guide niya.
Okay po, Doc.
If you have any questions, you channel it through Hannah and then Hannah will text me. I'll try to answer as much as I can. May utang akong dalawang slides, Hannah. The menopause and the precocious puberty.
Yes po, Doc.
Okay, sige.
Po.
If there's no questions, let's call it a night. Good night. Wait lang. Automatic na ba to? Oo, di ba? Pag college, automatic nila yung nagre-record.
Yes po, Doc.
Okay. Sige, thank you.
Thank
Good
you po.
night.